हम लोग और ज्यादा लग रही है क्या?
The fuck is this? Next 10. Switch. There we go.
Assalamu alaikum. Welcome everyone on board. Sorry for the delay. Actually, there was some problem in the internet. So I had to restart my device, both laptop and mobile. So before we start, any question from the previous discussions? Anyone wants to ask any question?
पेशेंट है उसका ब्लड प्रेशर लो रैंक पे है या हुआ था सी रेक्टम था
Please. Okay. Any question from the previous discussions, please? How many of you have dealt a patient with pericardium cardiomyopathy? Zishan, Dr. Haifa, have you seen a patient with cardiomyopathy, peripartum cardiomyopathy?
No, sir.
Have you seen a patient with cardiac failure in pregnant?
Not in.
Assalamu alaikum.
Yes, Dr. Haifa, what
Yeah.
have you seen? Have you managed a patient with peripartum cardiomyopathy?
Peripartum myopathy? No, but myocarditis, yes. Heart failure, yes. But peripartum myopathy, no. Because we don't do a lot of obstetric, Dr. Zishan.
Yes, actually, I will just to make it simple. I tell you something. It is just like any other failure. Okay, any other patient with heart failure, and the basic theory is the same. It's only only that if it is occurring in a pregnant patient after 20 weeks of gestation without any previous cardiac disease, history of any cardiac disease, okay, then we label it as peripartum cardiomyopathy. Okay, but the bottom line is that it is like any cardiac failure to start with, number one. And number two, when you are dealing with it, you have the same altered physiological, pharmacological, and anatomical considerations in a pregnant patient. So if you face this question in exam, the basic theory, you should be keeping this thing in mind. Okay. So what are the general principles if you have a patient with cardiomyopathy with to conduct anesthesia in patient with any cardiomyopathy? What will you doing? What will be doing?
So
Yes,
rate and
Ishan.
rhythm should be controlled, and
Okay.
afterload is to be maintained. Not much.
Would you like to quantify? You are jumping. Just would you like to quantify what sort of cardiomyopathy? Sorry, what? Forget about the cause, but what stage of cardiomyopathy it is? Okay.
Yes.
Because as much as the is the decompensation, as much as will be your care. Okay. So the same in New York Heart Association classification you will be following. Okay. So you will be on the basis of history, examination, and followed by ECG, X-ray, and echo. You will be quantifying. Yes, in case, if for example, if the patient is pregnant, you will try to avoid X-ray. You will be relying more on the other investigations. Okay. So first step will be quantifying it like any other patient with cardiomyopathy or heart failure. This is number one. Number two, what will you be doing?
Preparation.
Yes.
Means
Preparation means preparation means Zishan, in any patient. This is the basic. If you are practicing this thing in every patient, you will never miss it. Like the rules will be different if you are dealing an emergency or you are dealing an elective patient. Am I right?
Yes.
So you will be looking at the urgency of the surgery if it is an elective patient and there is some element of decompensation. you will try to optimize the patient. Am I right?
Yes, sir.
You will try to to have some optimization. Okay, so you will be doing some medical management to just to achieve a window period, sorry, a margin which is in the form of reversibility. Okay, so this is, I'm not talking specifically about peripartum cardiomyopathy, and actually these words can be used in any disease, any patient with any decompensation. You will be looking at the urgency of the surgery. If the
Yes, sir.
surgery is not urgent, you will try to optimize the patient. This is rule for every patient. Am I right?
Yes, sir.
And then the number, if for example, you don't have the time, then you will be doing the risk stratification. Risk stratification in the form of, what will you be doing? In the form of risk stratification. For example, if you have patient with the decompensated heart failure because of cardiomyopathy, and now you have to proceed with the surgery, what will you be doing?
Means we have to
Yes.
proceed with the surgery with the optimum precautions and selection
Like,
of our technique.
yes,
Sir.
like what will
Precautions,
you be doing? Like,
precautions like first of
because
all, we have to have
this this is
adequate
the
monitoring.
practice. This is the practice. Yes. So what will should be your answer?
Um, we will have an adequate monitoring, like standard one,
No, this is
standard
not a,
two
yes, in
monitoring.
addition,
Along
this
with
is
that, we'll have
in,
invasive monitoring for blood pressure, and preferably if the facility is available, we'll also like to have transesophageal echo.
okay. What else?
In monitoring, central venous
Yes.
monitoring, central
Yes.
venous.
Anything.
Yes, sir.
Something. Anything. You can say with the ability of the logistics, expertise available, and the, am I right?
Yes, sir.
If you have going for incident, the maximum you can do is just to have in so you are avoiding any swing of blood pressure, right? You are monitoring the beat to beat blood pressure.
Yes, sir.
Okay. So your according to the and the surgical risk. Am I right?
Yes, sir. So there is distortion in voice.
Yeah.
Is it on your side or mine? I don't.
Just a second. I think it
Is
is on
anyone
my
else
side.
feeling it?
Just a second. Let me try to fix it. Meantime, Zishan, keep what else?
Hello.
Else? Yes. Am I audible to you now?
Yes, sir. Better.
Yes. So I will repeat what I was saying, that if you have a patient with cardiomyopathy or heart failure, and now you are proceeding with the surgery, the first thing will you be seeing is the urgency of the surgery.
Yes.
Number one. Okay. And then if the surgery is not urgent, you will optimize the patient. If the surgery is urgent, the plan will be according to the surgical risk. Okay, because if you have a patient with heart failure, but you are only doing a minor surgery, low risk surgery like incision drainage, superficial surgery, okay, so the level of care required will not be the same. Okay, so if you have a major surgery in that same patient, the level of care will be more. Okay, so in addition, your answer will be, should for the oral examination part or even discussion, you see, if you practice this answer from the first year of residency, just tell me what will you be, how will you be feeling when you are appearing in the final exam? Okay, it will be just a piece of cake. So you say that in addition to standard 1 and standard 2 monitoring, I will be doing invasive blood pressure monitoring. If there is facility of pulmonary artery catheter or cardiac output, that will be giving me the exact fluid status and the right and left heart filling pressures. Okay. If not more than that, you can have CVP. Okay. If there is facility of T, you can do T. Okay. And then because this patient can decompensate, so maybe this patient might have the facility if it is required, or if it is like a condition a patient is requiring, maybe patient can have a pacemaker, or there should be a facility of artificial pacemaker, or you should be ready for any adverse cardiovascular event. Okay. You may attach defibrillator pad. You may have prepared vasodilators and inotrope and vasopressors with you. Okay. If you are answering in an oral part, you can say anything just to know the examiner that you are a safe anesthetist. Am I right?
Right.
And actually, if you practice this thing, any patient, any condition in which there is possible decompensation, you can chalk out these things. Okay. So after doing this, and of course, you will be discussing with the surgeon, and you will try to have minimum invasive surgery. Okay. So
Yes, sir.
we talk about, yes. And among the medications, what sort of medication would you like to do? And you can start from the pre-medication, anxiolysis, but careful. If there is if patient is retaining CO2, it will stimulate the sympathetic system and it will create problem. Okay. And it can cause hypoxia. In already patient with dyspnea, it can create a problem. Number one. Number two, you should have a post-operative. Yes, and another thing which I missed is the post-operative HDU monitoring or HDU care. Okay. Then you can plan for multimodal analgesia with some central neuraxial, with careful titrated doses of central neuraxial block, or any nerve block or wound catheter according to the situation. And of course, ruling out any patient taking any anticoagulants or antiplatelets. Okay. If you have to optimize those things according to the situation. Okay. Then among the induction agent, what you will be using and what you will not be using. Induction agent of choice in a patient with cardiac failure.
So titrated doses of propofol should be given and ketamine should be avoided.
No, this is not.
Why not etomidate?
Choice answer. Yes.
Sir,
Okay.
sir, if ejection fraction is low, then we can use ketamine too.
No.
No, it will aggravate the
Not used.
tachycardia, which is not good for heart.
For yes,
Etomidate
Dr.
will
Nashida.
be- sir.
Just a second. Dr. Nashida, what you are saying, please.
No, etomidate is a better choice because it is
Yes.
cardiac stable.
Actually, the practically speaking, if you can make a cocktail. Okay. You can make a cocktail in which you are blunting the stress response. You are avoiding excessive doses of different medications. Okay. Like for example, that you cannot actually defend in the exam. For the exam point of view, to be safe, you will say that I will be, because patient will be sensitive to the cardiac depressant effect of propofol or thiopentone, or even people don't understand that what is the problem with ketamine. Even if patient with low ejection fraction, would you like to induce exclusively with ketamine? Tayyab, you
No,
said, please, can you
ketamine-
just just a second. Tayyab, would you like to just highlight, if, for example, if a patient with 20% ejection fraction, would you like to induce exclusively with ketamine?
No, sir, with OPIs, lignocaine, this combination will be given.
Yes, actually, ketamine is a wonderful medication. Okay. And there is actually, practically speaking, there is no contraindication to ketamine if you are using it in a proper way and in a low dose. But if you are trying to induce exclusively with ketamine, or you are giving a higher dose of ketamine, it is not good for any patient. Okay. This is my personal experience, and maybe experience of a number of people who are listening. Okay. Because ketamine increases the secretion, ketamine increases the heart rate, it releases catecholamines, so it will create a lot of problems if you are using it exclusively. But if you are using it in a proper way, it is not contraindicated in any patient practically. Yes, in the exam you cannot mention these things, but I'm just telling you that practically low dose of ketamine is a magic for any patient. Anyways, for exam point of view, in this scenario, it is better for you to say about the induction agent as etomidate. Okay. Because you cannot defend any other induction agent in the exam. Okay. So it is better for you to say etomidate. Zishan, in your imagination, if you are, I can agree with you that you can use a titrated dose of propofol, but in the exam, please never say this. This is a question which will fail you, I guarantee. That if you use propofol in a patient with cardiomyopathy, you will not be able to defend your answer. Okay. So it is better not to take a chance. What about muscle relaxant? What will be the care in muscle relaxant? Yes, Nashida. Who wants to answer? Zishan?
Sir, atracurium non-depolarizing muscle relaxant should be used.
What about saxamethonium? I'm sorry. Yes, unmute, please. Zishan. Yes. Would you
Saxamethonium,
like?
sir, I can't think of any contraindication.
If it is actually, you see, it is causing hyperkalemia. It can
Yes, sir.
cause bradycardia. It can cause, like, for example, if these patients with cardiomyopathy can be on digoxin, okay, they can be on ACE inhibitors. ACE inhibitors cause hyperkalemia. Saxamethonium can aggravate it, okay. So any medication which is causing any cardiovascular stress, it is better not to give, okay. So if you have other choices, it is better to use other choices. Rocuronium can be given. And the medications which are releasing histamine, practically you can use them, but theoretically it is better not to give them, because again, they can give an unwanted response. Okay. So if you are talking about that thing, it is better to tell cisatracurium rather than atracurium. Okay. And for or for in emergency, it is better to say rocuronium with the availability of sugammadex. And if you are using saxamethonium, you should be ready for any unwanted response. Okay. Of course, you can use the word for oral part. You can use this word, I will outweigh risk versus benefit. This is a smart answer. Okay. Nobody will fail you if you are saying that if you are using saxamethonium, these are the problems which you can have. But if, for example, airway is compromised, patient is in emergency, patient is full stomach, and there is no other option other than to use saxamethonium, you can use it. It's not like absolute contraindication. And I will outweigh risk versus benefit. I will see what are the risks associated with it and what are the benefits. Okay. So actually, no answer is perfect. You just have to defend it. So I think, yes.
Sir, in PPCM, patient is full stomach. We have to do RSI. Can we use saxamethonium?
That's what I'm telling you, that it is risk versus benefit. If you are using it, you can expect instabilities. Okay. You have to anticipate the problems because maybe in other patient, transient hyperkalemia is not creating any problem. But if the patient is on digoxin for heart failure, and now you are giving dexamethasone, this can create a significant problem. Okay. Or if a patient is taking ACE inhibitor, this can be a bigger, if the gravity of the effect may be more than in any other patient. Okay. So in the actually in oral part, they are expecting you to be safe and smart enough to defend your decision. Even if you are doing something unwanted, you have to defend it or whatever, because there is nothing safe. In such patients, we will just discuss that what is the choice between regional anesthesia and general anesthesia. There are a lot of things which are in favor of there are a lot of problems in either of the techniques. Okay. So you have to just choose and use that technique in a careful way. Okay. Because nothing is safe. You are in danger all the time. If you are giving, for example, spinal, patient can decompensate suddenly. You cannot give too much fluid. So spinal is not a good choice. Yes, epidural with titrated doses and combined with opioids, this is a good technique. You can use it, but still you are not 100% sure. Even if you are using epidural for exclusively for the conduct of anesthesia, you need to give higher concentrations and higher volume. So it can cause significant sympathectomy. So patient cardiac output can further deteriorate. Okay. But if you are using, for example, general anesthesia, and you are not able to avoid the stress response, for example, you are not using you are having problem in laryngoscopy, and you are not blunted the stress response in a nice way with a combination of a number of medications you can use. Yes, you see, in other patients, you can give esmolol, for example, beta blocker. But in this patient, maybe even a small bit of beta blocker can create a significant effect. Okay, because beta blockers are also given even in heart failure treatment. But this is the question mark. You have to use opioids tactfully. Okay, so you can do it, but it is not the technique. It is the way you are managing it. So combination of epidural with general anesthesia, with close monitoring and titrated use of medications will give you a very good result. Okay. So in the exam, you will be saying it that this patient needs meticulous monitoring, and no technique is 100% safe. So you just have to outweigh the risk versus benefit and chalk out a technique which is the safest for the patient in that scenario. Okay. So this is how you can answer this question. So we discussed about induction agent, muscle relaxant, analgesia. You can avoid the medication which are causing tachycardia, like pethidine, tramadol. Okay. If you are using dexmedetomidine, this will be again according to the situation, because dexmedetomidine can cause bradycardia. It has a lot of effect on the sympathetic system. So maybe it is not as safe as in other patients, but it can give. If, for example, if the patient is having tachycardia in this patient, it will be a very good choice. You can titrate the dose. Yes, Dr. Mahjabin, you want to ask something?
Yes, I want to ask that why have we preferred cis-atracurium for
Cis-atracurium does not release histamine. Okay.
Okay.
It is it's a muscle relaxant which does not release histamine. Okay. So these are the things. So like you have to make a judicious fluid management plan. Okay. This will be part of your care. Multimodal analgesia plan and paracetamol you can give. And said apparently there is no problem. You can give it as a part of multimodal analgesia unless there is any other contraindication. Okay. Or for example, any element of renal
also.
rocuronium I have already
Also
discussed.
okay.
Dr. Humera, you have already discussed rocuronium, please. Okay. So, in what about awakening this patient? Yes, Ishan, would you like to have something different in this patient?
Sorry, what was the question?
Awakening the patient, reversing the patient. Would you like to give newstigmine and would you? Is there any problem in giving reversal?
Sir, if we are using non-depolarizing muscle relaxants, preferably we should avoid
Your voice is
the
gone.
use of newstigmine and glycopyrrolate. Hello? Hello?
Yes, yes. Your sound is not coming clear. It is better if you use cis-atracurium, because cis-atracurium will be metabolized in. Yes, Dr. Nashida.
Sir, newstigmine will cause bradycardia. So during
Yes, Dr.
reversal,
Nashida, you want to say something?
Yes, sir, newstigmine will cause
No.
bradycardia, right? During reversal.
No, but you never give newstigmine alone. You
Yes,
never
so
give
that is
newstigmine
why,
alone. You always give.
If you're giving, yeah, first you have to give glycopyrrolate and then newstigmine for reversal if you're planning.
It is an answer, but actually there is a better answer.
Okay.
That it is better you give cis-atracurium, which is metabolized in the blood, and actually, if adequate time is gone, you can just do the nerve stimulator, and maybe you don't need to reverse. Okay, you can avoid reversal. This is one answer you can give. Other answer is that if you are using rocuronium, it is better to reverse with sugammadex. Okay, because you will avoid newstigmine, you will avoid glycopyrrolate. This is another answer. Number two. Number three answer is that you are using a technique in which you are not using muscle relaxant at all. After, for example, you give succinylcholine and you are not giving any muscle relaxant, and you can do. This is another answer. Another answer is that, for example, there is no other choice and you have used muscle relaxant and now you are reversing it. It is better not to give atropine. Okay, if you want to give a combination, combine newstigmine with glycopyrrolate. Okay, so that's the answer which you should be giving, and it can cover any. Actually, this answer can be there in any patient. Like even for this same answer, you can give for ischemic heart disease. Same answer you can give it for hypertensive patient, and same answer you can give for heart failure. Okay, so actually this is the default answer which you can give in all of them. Okay.
Okay.
Okay, so this patient should be monitored in HDU. Okay, so now we will just come to the I will just share the screen just a second, because actually the topic was peripartum cardiomyopathy, but I just discussed the baseline concept which you should be using in any patient with any cardiomyopathy. Okay, and there will be the basic parameters will be like that, and now we will be seeing that what is peripartum cardiomyopathy specifically. Actually, the etiology is that it is the rule of exclusion if there is a heart failure after 20 weeks of pregnancy, and you don't have in this patient there was no previous history of any cardiac disease, no valvular heart disease. Okay, that this is the diagnostic criteria. Heart failure developing towards the end of pregnancy or up to 5 months postpartum. Okay, can you hear me? Is my
Yes, now we can hear you clearly.
am I audible to you? Yes, Dr. Nashida and anyone, are you people
Now it's
able to
better,
listen?
sir.
Yes. Okay. So at the towards the this is some words about peripartum cardiomyopathy. Okay. So you have a heart failure towards the end of pregnancy or up to 5 months of postpartum, absence of any identifiable cause of cardiac failure, and absence of cardiac symptoms before pregnancy. Okay. And then there is failure of left ventricular function. Okay, so this is the differential, this is the diagnostic criteria for peripartum cardiomyopathy. They can ask you directly what is peripartum cardiomyopathy, but it is, I think they will give you a scenario in which in which they will be telling you that in the end of pregnancy, they will be giving you a scenario with dyspnea, and you can give a differential diagnosis of, for example, any respiratory problem, any cardiovascular problem, any decompensation as a patient with in preeclampsia. Okay. And then if they want to ask you specifically this thing, they will give you a hint that there is no other cardiac disease. So you will be saying that this is maybe most probably this is peripartum cardiomyopathy. Okay. And you can see the differential diagnosis: pulmonary embolism, severe sepsis, amniotic fluid embolism, preeclampsia, and any other cardiac problem, severe anemia, arrhythmias, okay, and dilated cardiomyopathy of any other etiology, like it is there, okay. Any viral infection, any bacterial infection, bacterial endocarditis, okay, anemic heart failure. There is high output cardiac failure and then the patient will be decompensated and the result will be the same. And any other cause of dilated cardiomyopathy, it is chalked out here. Okay, we have already actually discussed everything. So ECG, echo for diagnosis, cardiac MRI. This is actually specifically the things related directly to and the cardiologist actually, but you should be knowing what this is. What we have not discussed before. Actually, ANP and BNP, these are the markers, and which are also for diagnosis and also for prognosis. Okay. But it will be only there with the combination of sign and symptom, like it is not sensitive. Okay. But it is used as a tool to see the prognosis. Okay. So this patient may be having dyspnea, short like exertion orthopnea, okay, and then there may be some arrhythmias, just like any other heart failure. There may be signs of ischemia, okay, and like in the form of pulmonary edema or pedal edema or this one raised JVP, because usually it is left ventricular failure, but it can cause the back pressure, and then there can be development of congestive heart failure as well. Okay, so any arrhythmias can be there. We have discussed these things in our prior discussions as well. Okay, and it is a leading cause of maternal death. Okay, and as I told you, New York Heart Association classification or by echo, you will quantify or classify the severity. Okay. And management will be the same: multidisciplinary, obstetrician, cardiologist, obstetric anesthetist, okay, and neonatologist, because maybe you need to deliver the baby premature and the baby may be going to an ICU, okay. And what else? Yes, pharmacological therapy, the same, AC inhibitors and hydralazine, nitrate therapy. Actually, this is the same. And because usually the ACE inhibitors may be not given in the first trimester, it also has teratogenic effect. But in later half, because it is occurring usually in the later half of pregnancy, so you can give. Okay, and digoxin. You see, I have discussed actually a number of things before. For the symptomatic relief, you are giving some loop diuretics. Okay. Okay, this is something new I didn't know. Aldosterone antagonists such as spironolactone are not recommended during pregnancy. Do anyone knows about it? I have no idea. I didn't know about it. This is just I have read now. Okay. We will discuss the role of intra-aortic balloon pump. If you have not heard, here you can see in our discussion of cardiogenic shock. You will find what is the role of intra-aortic balloon pump, what is the role of left ventricular assist device, okay, and as a last resort, if nothing is working, heart transplantation. Okay, so if there is the history before, there are chances of again, okay, reoccurring. So this is an anesthetic consideration we have discussed before. They can prepare this, they can optimize the patient with some medications. Okay, and you see vaginal delivery option for the patient with compensated peripartum cardiomyopathy. Otherwise, they don't go in the labor and they do elective cesarean section. But this will not be your decision. you will be discussing with the obstetrician, and you will try to. Okay, so what else? These are general considerations in any other pregnant patient. We will, inshallah, discuss the details of obstetric anesthesia a few weeks before we did before. Okay, and yeah, like I discussed with you, neuraxial titrated doses, incremental top up. Okay, segmental, combine epidural with the low dose spinal anesthetic technique. Actually, again, in the articles, a number of things are written. Okay, but it is better not to quote everything. You cannot, maybe you are not able to defend this answer. So don't quote everything. Okay, because a spinal will not be a good choice. If you are talking about central neuraxial, epidural is a thing which you can defend. Spinal, it will be difficult for you to defend. Okay. Minimize both hypotension and hypertension. Pressure response to laryngoscopy and intubation should be attenuated. Okay. Rapid acting opioid like fentanyl, remifentanil, inotropes like dobutamine, calcium sensitizer. This is, I don't think so. This is available. Have anyone used this? Levosimendan. I have never used it, so I have no idea about it. Milrinone is there for the right heart failure. This is a very nice medication, but whenever you are using Milrinone, there can be severe vasodilatation and patient can go in hypotension actually. So you have to use it carefully. Okay. Again, the concern will be oxytocin. It will not be a good choice to give. There is another new medication, carbitocin, which is relatively long acting, and it has less cardiovascular effect as compared to oxytocin. If you are using oxytocin, try to avoid boluses. You can give an infusion in low dose. Okay. If you have to give bolus, you should not be giving more than 3 to 5 units. Okay. Yes. And ergot, again, which will increase in afterload and it can aggravate the symptoms. Okay. So because I discussed these things in our background discussion, and the same features will be there in any other form of cardiomyopathy. Okay. So any questions, please? I hope you understand the basics which we are trying to discuss. The basic thing, remember one thing, the basic goal for managing any patient with cardiovascular problem. If you forget in the oral part, you will be saying you will be optimizing any reversible component of heart failure or any reversible ischemia. You will be looking at if the patient surgery is elective, you will optimize the patient. If the surgery is urgent, you will proceed with risk stratification, invasive monitoring, and minimizing the myocardial oxygen demand supply ratio disparities. You will try to increase the delivery and reduce the requirements. So you will be avoiding the stress response. Okay. And rest of the thing which we have discussed, you can mention in any cardiac patient, by the way. The same, if you understand this thing now, the same thing will be there for valvular heart disease. There is no difference. Absolutely the same theory which I have discussed. If you understand this thing, it is almost there for valvular heart disease. It is almost there for any heart failure. It is almost there for uncontrolled hypertension, because you are just trying to avoid the end organ failure. Okay. If the patient is having any problems of arrhythmias, any atrial clot, you are giving the anticoagulation. If the patient is on anticoagulants, you have to monitor and use your anesthesia accordingly. You will be avoiding if the patient is all continuous on warfarin or continuous on, you will try to avoid neuraxial block. If you want to reverse it, you will reverse it with prothrombin complex concentrate. If the patient can receive FFPs, you can give, but otherwise you will avoid it, because if you are giving 1 liter of FFPs to correct warfarin, it is better not to use neuroaxial technique, and any surgical technique they are using it, you will be using it you will be reversing it carefully. Okay, so these are the basic principles. So any questions, please? Okay, so tomorrow we will just discuss intraoperative myocardial infarction. Okay, thank you very much.